Hello, welcome to tonight's webinar. Thank you all for joining us. We'll get things going in a couple of minutes and I'll fill this time with some housekeeping. I'm Alex Allen, the Systematic Literature Reviewer and Guideline Development Manager at BSR, and I'm a facilitator and moderator this evening. My colleagues Daisy Southern and Ross Matthews are also here behind the scenes, facilitating and moderating to help the webinar run smoothly. I'm joined here on screen by our host this evening, Dr Elizabeth MacPhie, consultant rheumatologist at Lancashire and South Cumbria NHS Foundation Trust. She is also the chair of the BSR Clinical Affairs Committee. A quick outline of how things will work before I hand over. We are scheduled to finish at 7:45 p.m. There is a chat function on the right of your screens. You can post your questions in here, share your experiences. We do want to hear from you and let us know if you have any problems at all. If you do have technical issues, please try refreshing your window or let us know in the chat box and we'll try to help. The session is being recorded and will be available on the e-learning site in the next few days, and you will receive a certificate.
We seem to have lost Alex, but as Alex was saying, that you will receive your certificate in the next few days. So just look out for those with your email, within your email, and I think that he's covered everything in terms of how to use the platform. As he said, post your questions for our speakers in the chat function, and I'm just going to pass over to Lizzie now to begin the session.
Oh, thanks, Steph, and thank you, Alex, and sorry you got interrupted. It's a bit daunting. I didn't know whether it was my computer that had frozen or Alex had dropped out, but we're having just a few little blips with the connections. So please, if I suddenly drop out and people can't hear me, just put something in the chat and then we'll try and reconnect. But as I've lost track now of what number webinar I'm up to hosting, but it's a pleasure as ever to be back in the hosting seat and to be hosting this BSR webinar regarding the guidelines. And Alex there is a really welcome addition to our BSR team to support our guidelines and their production. And one of the reasons we've got a webinar tonight about guidelines is because these are a really, really valued resource by all BSR members. The last couple of surveys that we've done of members have highlighted it as one of the top reasons and one of the top benefits that they get from their BSR membership. In the 2018 survey, it was number 3. In our survey this year, it was the first. So clinical guidelines and best practice were the top member benefits. So we realise that our guidelines are very valued by our members, and it's great to have 2 of our guideline writers on tonight and our current chair of the Standard Order Guidelines Working Group. So just to run through, we're really keen for it to be an interactive and chatty webinar tonight to talk you through how guidelines get developed and those personal experiences from 2 of our experts. So what we're going to do is have a question and answer session with me posing questions to both of our presenters tonight. And then as ever, we will open it up to answer some questions from the floor. So please, as our BSR team have been highlighting, use the chat, post your questions, and we'll pick those up with the discussion. And we've got about 15 minutes for that chat at the end, and we'll try and get through as many as possible. I'm going to ask Ian, Giles and Sarah Mackie to turn their cameras on just while I highlight a couple of other little things. One was just to signpost members to a new page that we've got on our website, which is under Practice and Quality, and it's a policy page, and I'm just going to flag all the hard work done by the Clinical Affairs Committee, various guidelines and, well, not guidelines, I should use that term carefully, guidance and top tips that we've produced over the last few months have now been made very much more accessible for members. So So that's a really good page to for you to direct yourselves to and pick up on those resources. And the other thing to just highlight is that we have got an extra webinar this week related to the updates around going back into lockdown, and an update discussing shielding and such, because we've had an awful lot of questions through in the last week. So just to make sure I don't forget at the end to highlight that, that's on Thursday, and all you members should have got an email today. So to introduce our two presenters today, we've got Sarah Mackie. Sarah is an Associate Professor in Vascular Rheumatology at the University of Leeds and an Honorary Consultant Rheumatologist at Leeds Teaching Hospital NHS Trust. Her clinical and research interests are giant cell arthritis and polymyalgia rheumatica, and Sarah led the most recent GCA guideline that was published in March this year. And then we've got Professor Ian Giles. Ian is the current chair of our BSR Audit and Guidelines Standard Working Group, and he has a wealth of experience both from chairing that group and overseeing many recent BSR guidelines. Day to day, Ian carries out his academic work at University College London and is a consultant rheumatologist at University College Hospital. Ian was the lead for the two guidelines on prescribing drugs in pregnancy and breastfeeding, published in 2016, and just started now on the review process. So I'm going to go straight into our first question to both of our panel members. So our first question is to both of you: why did you get involved with writing a guideline? So I'm going to come first to you, Ian, for hear your thoughts.
You can all hear me. Thank you for that introduction, Lizzie, and thank you BSR for organising and hosting this and giving us the opportunity to talk about a subject that's very close to my heart. But it's something which I really began with no experience and was purely based on a clinical question. So we're all familiar with situations where the patient in clinic asks you a question and you have an incomplete and unsatisfactory answer. And through my work in an obstetric rheumatology clinic that's been going on for 15 years now, I was forever trying to answer questions as best I could asked by patients around whether particular medications were safe in pregnancy. And it was clear that there was not just a huge sort of gap in the evidence, but that there was a lot of incomplete and unsatisfactory advice written in a very negative manner. So it was purely a desire to try and form better answers to those questions that I got a group of people together, some established experts in the field, as I saw it, and asked them the question. And when they didn't know, someone had the bright idea, well, maybe we should write a BSR guideline. And that's where it started from, really.
Great. And Sarah, what was your reason for getting involved with writing a guideline? Oh, you're on mute.
Can you hear me now? So
yes.
So my story is a little bit different from Ian. So you very kindly said that I led the guideline, but actually the real leader of the giant cell arthritis guideline was Bhaskar Dasgupta. So he wrote the original 2010 BSR guideline on giant cell arthritis. And he decided in 2014 that this required a major update. And so he got a lot of us together, not just rheumatologists, but also ophthalmologists, nurses, patients, and all sorts of other stakeholders, and got us together as a group to say, come on, let's do a major update. And so I guess part of my reason for getting involved was the persuasiveness of Bhaskar Dasgupta, and also just because I grew up with evidence-based medicine. When I started as a medical student, it was the big thing, and David Sackett came and spoke to us very early in our medical school, some of our first clinical lectures. And I've always been interested in that process of producing evidence and trying to collate the research evidence to make it actually usable for clinicians. And as I've gone on as a clinician, I've appreciated BSR guidelines more and more. So I just really wanted to help collate that evidence for all practicing clinicians and patients, so that we could synthesize that evidence and clarify what the current state of evidence was for giant cell arthritis.
Great. And can you both talk us through what you did, what the process involved? So again, Ian, I'll come to you first.
So having formed that initial sort of what was a very small group of people and got an affirmative that yes, the BSR are interested, we had to basically expand our group and learn all about the process that would be involved. and that was quite an undertaking in itself. As Sarah mentioned, there's a systematic review process that lies at the heart of every guideline, but there's also a whole other process around grading of evidence, formulating opinions, getting a consensus of opinion from the group, and phrasing of questions, not an alteration, but a sort of a phrasing of questions and a nuancing of answers around the evidence that you had. And so it's important to get a widespread of interested parties in your working group. Although initially we might have just started with rheumatologists, we had to expand to involve obstetricians, obstetric physicians, pharmacists, general practitioners, nurses, and of course lay representation is very important on a working group. And then go about the systematic review process and the grading of evidence and learning about working within the group and trying to work with your normal working activities as well. Doing this in addition to the day job does present quite a challenge, and a lot of this work inevitably falls into your own hours, evenings and weekends. Many happy hours distilling evidence from publications, grading the evidence, and then discussing it at subsequent meetings. But that in essence is sort of the process that we then follow.
Great, thanks. And Sarah, can you talk us through sort of what you did? Because I think yours was a slightly different journey, wasn't it?
Yes, so we had just come from writing the ACR EULAR guidelines for polymyalgia rheumatica. So for that, we had used, was part of an international group, we had used the GRADE process. So we were at advantage there because we felt we were quite familiar with GRADE and how it works and the process that we needed to go through in terms of identifying critical outcomes and then PICO questions and going through that process there. And we were very fortunate because we were able to, we had quite a few international authors and a very hard-working systematic literature review team, and we ended up reviewing not only management, so therapeutic management of giant cell arteritis, but also diagnosis, and we also had a team looking at prognostic factors for giant cell arteritis. So there was 3 parallel systematic reviews going on, which was a huge amount of work, but they were done by a very experienced team who had recently done it for PMR, and so actually from the perspective of most of the group, that GRADE process appeared to be relatively smooth. So I played a role in the systematic literature review, but not a major role. And most of my involvement came after that, after those results were presented and collated and we were getting stuck into the writing.
Great. So there's 2 things that sort of have sort of grabbed me: this GRADE methodology, and Ian, you mentioned the sort of process, which is as we've got our BSR protocol, which takes you through those steps. There's a very specific path that you have to take, isn't there, to develop the guidelines? So I think as far as the sort of talking through the sort of nuances, we can go into more detail if questions come through about what those processes involved. But I'm keen to sort of come to both to ask you what it was like. Was it a difficult process, Ian?
So it was a very challenging and a very difficult process, and I think it's really important to pick up on a point you just mentioned, Lizzie, that throughout we were following a nice accredited process, because of course that's what the BSR protocol and the guidelines are. So you know that you're really getting, that's a real tight mark of quality, I think, on the product that's produced by the BSR from the Standard Audit Guideline Working Group, which sort of oversees the production of all of the guidelines. And the fact that NICE has sort of given its quality mark for this process really shows the rigour and robustness and transparency that is applied to that. So it is challenging to go through this process. I mentioned you have to learn about all these different terminology, acronyms of this, that, and the other that guide you through the process. And you have to devote a lot of time to it. You have to devote time to the sort of, if you like, the gathering of evidence, but the pulling people along with you. Sometimes enthusiasm can wax and wane, and you've got to try and be responsible for delivering the energy, making sure that you sort of always push an agenda forwards to each meeting so that people have something to comment on rather than expecting them to sort of thunder up things in air. That's the job of the guideline lead, unfortunately. And and then just helping to sort of move this, what was once an idea from around a table of a few people, to become something that's written down and a robust sort of listing of recommendations. So yes, it is challenging, but ultimately very rewarding.
Great. And Sarah, how did you find it a difficult process?
Well, I think it probably different members of the guideline group would say different things. So as I said, we were so lucky to have Christian DiGiacomo leading the systematic review, because he's one of the calmest people I've ever worked with, and he made it look like there was no stress at all. Or I'm sure it was a lot harder to lead this massive 3-pronged systematic review than he gave the impression. But so he produced these lovely evidence tables. We went through questions, evidence, recommendation. We got a draft guideline. We sent it to the BSR, and then we got some peer review comments back that were quite challenging. And it emerged that the way that we produced our guideline, which was quite similar to the way we produced our PMR ACR EULAR guideline, wasn't quite what the BSR wanted to see for a BSR guideline. So this was quite challenging, and we took this back to the group, and then we prepared our response. But then in the meantime, the pivotal clinical trial of tocilizumab in giant cell arteritis was published, and we wanted to include this in our guideline because clearly it was really important to describe the role of tocilizumab in a GCA guideline, and this was in 2018. Or perhaps 2017 or 2018, a couple of years ago now. So after much negotiation, we accepted that we had to go back and we had to update our entire systematic literature review, not just the treatments part of it, but also the diagnostic part of it, and also the prognostic part of it, to make sure that all those systematic literature reviews finished at the same date, which was after the GIACTA study, so that we could include the GIACTA study and summarise all the trial evidence on tocilizumab as part of the guideline. So this rerun of the searches had to be done in exactly the same way as the original searches, and we were lucky to get an extra person, Gary Reynolds from Newcastle, who helped us with a lot of that. And we then had to synthesize this new evidence, go through the grade process all over again, produce new recommendations on the basis of the new evidence, and this was quite a time-consuming process. And we then had further peer review comments after we submitted our revised version, because still, the peer reviewers wanted us to improve it. So from that original, yes, we've done great and we're fine, it then got quite challenging, just to with everything, the combined force of circumstances, and it was. And we needed to re-vote on our recommendations, and it took a while to get that initial guideline draft to the guideline draft that was finally submitted and accepted for publication.
No, so quite a different journey for both of you, but equally lots of hurdles to jump and such. So I suppose the $1 million question to both of you is, would you do it again? So, Ian.
So yes, and in fact, as you mentioned earlier, we've restarted the revision process, because you sort of merrily write. It's one of those easy things to write in your guideline when it's going to be updated. And I might have initially crossed out 3 years and written 5, but even those 5 years have now passed, certainly since the time when we finished our search date. So alas, we now have to restart the process all over again. And I can echo what Sarah said about the robustness, if you like, of the process and the number of revisions that come back to you as well. And having sat on both sides of the SAGWA committee, I can tell you that I've suffered, and not deliberately, mind, made others suffer through the delivery of comments. I think it just helps to add to the process that the guidelines go through. And I'm only one of many offering comments, so I'd like to point out to all guidelines out there, it's not me that's delivering these remarks that make you suffer long hours at night. So it is worth it in the end, because when you sort of formulate these guidelines, you have things written down, and you start to put the message out there and get a positive reception, it is fabulous. And I think we knew we knew because of the topic for us that prescribing in pregnancy is one that really troubles people, that people were desperate to have something written down in a sort of formalized fashion with recommendations from the working group, that we had a receptive audience, and it was really rewarding to get sort of lots of positive feedback. So from the presentation at the BSR conference, from membership, from colleagues, and also from people in other countries and other continents. So that includes comments from Australia and India, people who've sort of come up to me and said, I use the guideline. I have, there's a particular summary table with yes, no. It's all anyone wants to know, to be honest. No one's read the full guideline. They just want to know, is the drug safe in pregnancy, yes or no? And that summary table people find very helpful. So it is great when you get that feedback, and we know from the data that the journal collects that the BSR, the pregnancy prescribing and pregnancy guideline, is still one of the most popular downloaded and we assume read guidelines. But we do need to update it, so that's why we've restarted the process again. It'll be slightly different sort of next time round. For all of the guidelines, actually, and there's a scoping document that will start to be produced that will give people an indication of any new guidelines that are coming out and upcoming revisions to established guidelines.
Great. And Sarah, how about yourself? Would you?
Well, I thought
would you do it
we did
again?
it again while we were doing it, given that we had to repeat all the searches and then go through the whole great process all over again. So, so being slightly still traumatized from that process, I think I would say that what really drove it in the end was the fact that there was substantial new evidence that had come out since the last guideline. You know, there had been a huge amount of evidence on imaging for giant cell arteritis, which is just totally, it's still an evolving field, and it's still being discussed, you know, across the world, the role of imaging in giant cell arteritis, and we're still trying to find out about it. And then the other thing that was new is tocilizumab, so the first licensed therapy for giant cell arteritis and steroids. So because of those two major advances, we really, really needed to get a new guideline out. And that's why, in the end, that major revision really, you know, we all had the commitment to see that through. So I would say that if there is significant new evidence that comes out on giant cell arteritis, then actually it would be really helpful to repeat that guideline and revise that guideline again. But I would not do that, do it just for the sake of doing it. There has to be important new evidence, because it is a lot of work to do that.
Mm-hmm. And we have, there's a process in place, isn't there, for a major or minor revision? And then there's also the question, you know, if there's not been any major changes, then it's permission to sort of press the pause button and review again if something major comes out. So there's a process in place, isn't there, for that? So I think it's fair to say you are both extremely proud, and should be extremely proud, of the guidelines that you've been involved with developing, because we know how valued a resource, and we also know how much they're recognised internationally, how much they're downloaded, and there's also been, you know, numbers of audits done against the guidelines that we produce for the BSR. So I think the members speak for themselves as rating it as one of the most valued membership, and sort of fit what you get from being a BSR member. And I think what's really, I think, helped is like Ian has highlighted, is that we're investing more in the guideline process with employing someone through the BSR to support the groups, recognising how much work it entails and how much has to be done sort of in people's own time, so to speak, doesn't it? So so we've sort of come to our section of Q&A section. So we've had some really good questions put through. So the BSR team will feed us through questions, but there was one which I thought was just, I was keen to pick up, was how do patients get involved in the process? So how do they get involved? That's one of the first questions I saw coming through on the chat. I was wondering, Sarah, if you could sort of talk us through how you have patients involved in your guideline.
We were really lucky, because there's a patient charity called PMR GCA UK, which is specifically for patients with PMR and GCA. And so by means of that charity, we were able to reach out to patients sort of up and down the country who weren't under our own care personally. They were independent people that they were presenting their perspective as patients. And It's really important to not just have one token patient. You need to have substantial patient involvement, and we had 4 that saw it through right to the end, and more that were involved at the start, that because it was such a long process, they didn't quite make it through to the end without saying, actually, this is too much work and I just like to step back now. But we had 4 who actually stayed with it through the whole way, and their experience, their insights were really, really crucial, and we ended up having separate patient teleconferences sometimes, just to make sure that we could really get that patient perspective, and listen and give patients a chance to speak and be heard about their perspective on the guidelines, because actually their input to what we ended up creating as the guideline was substantial, and I think it would look very different without patient involvement.
And the patients are involved in the voting process as well, aren't they, on recommendations?
Yeah, they have an equal vote with any clinician.
Yeah. Yeah. So, and Ian, with respect to the drugs in pregnancy, how did you involve patients in that?
So as I mentioned, it was sort of initially the whole idea, the genesis for this came from the desire to sort of better answer patients' questions. So that was from routine clinical encounters, but we'd also done some patient public engagement work to sort of try and address what were the key issues that patients wanted to have understood. And one of those questions that kept coming up time and time again was, how does this medication, or how might this medication affect my pregnancy? So I think they were very sort of involved in the initial sort of genesis of the questions. And then at the time we were sort of producing our guideline, the BSR requirement was just for one patient in the working group who was involved throughout and would help to influence what we were thinking and what we were saying, and was a key part of the voting process. But the protocol, the BSR process, has now changed slightly, and so every guideline will need at least 2 patients. And as Sarah mentioned, they had more, so they're exceeded the requirement.
Great. So can I have our next question through from our oh, this is a good one. So how easy is it to reach a consensus amongst the various specialties? So I'll come to you, Ian, first with that one.
So it can be challenging, that's for sure. So for our guideline, our specialities involved was it rheumatology, obstetrics, and obstetric medicine. And so people do come at things from slightly different angles. And that's why you definitely have to go through an iterative process to formulate your recommendations in answering your questions. So you're not changing your questions, but you're refining your answers, because in order to really have a recommendation set down in the guideline, you need to have more than 70 or at least 80% consensus. And the first time you put that answer down in writing, you're unlikely to have had that degree of consensus. So then, but you have to have something to start with, and then you just sort of refine and try and understand what it is that people don't like about what you've said initially, and then revise the question so that it still fits the evidence, but people are much happier with the answer. And that goes on not just through the guideline working group meetings, but there's a bit of that in some of the pushback that comes through the review process as well. So we definitely had to change some of our initial answers, where I'd gone for a strong desire to be evidence-based, and I'd said, there's no evidence, I can't tell you anything. And we were pushed slightly to produce some more evidence-based answers based upon sort of, if you like, knowledge of a structure of a drug based upon limited information from something else. We might then put some information about where it could potentially be used, but without necessarily giving a full-blown recommendation of safety. But it's difficult.
Mm-hmm. And so have you got anything more to sort of add to that? Because that was a very detailed answer from Ian, and talked us through. But any other sort of, because you had different specialties, obviously, in surgical
we
as
did.
well.
So we had ophthalmologists involved, and Susie Mollen and Owen O'Sullivan stayed with it right from the start, right from an early meeting 2014 right through to the end. But because of the way in which we had done the process, and because it was very inclusive of all the guideline group members, it didn't really feel like there was conflict between ophthalmology and rheumatology. It felt like we were each contributing our own expertise, and we definitely had an understanding that there are some questions which are ophthalmology questions, which really the ophthalmologists would be listened to on, and then other questions which are more rheumatology questions. And then there were questions which we both had to reach a consensus on. And there was a little bit of back and forth, but it felt very collegiate and very constructive. That's a testament to the Susie and Owen. And I think Susie's been involved in other ophthalmology guidelines and knows the guideline process, so that helped an awful lot. And as Ian alludes to, the stakeholder consultation phase was very illuminating, because I think in retrospect, it just highlights the value of the scoping process before you even embark on the grade technical stuff. So the technical grade stuff sounds daunting and challenging, but actually it's a process. You follow the process, it's fine. The scoping process is really important to identify who's got an interest in this question. So we didn't think that we should include someone on the group who was a vascular surgeon or a general surgeon who was asked to do temporal artery biopsies as a service. But I think some of the pushback we got was from people, who weren't necessarily in our, so they didn't see themselves as GCA specialists, but they saw themselves as being involved in the process. And I think the way that we wrote the guideline, that we didn't take account of their perspective enough at the time that we wrote the original thing, and so we got a lot of pushback. Although the other thing I'd say is that pushback is inevitable in a rapidly changing clinical area, and if you don't create pushback, then your guideline has been useless, because you're just telling people things they know already. If a guideline is to change things, it will create pushback at the stakeholder consultation stage, and it's a sign that you're doing it right. But then the challenge is making sure you respond to that feedback in a way that you get listened to when the guideline's published. So it's a bit of a fine line to tread.
No, and well trod, both of you. So, and I suppose there's something I remember when I was used to chair the standard audit guidelines group. One of the tips is to have an odd number of people involved in the process in case there is. Is that that helps with the voting? I understand.
We never vote. We never.
Yeah. Right.
It was that we were never 50-50 on anything. We were, because of the way in which we had gone through the process and involved everyone very deeply all the way through. By the time we got to the voting, we were all fine.
You had that consensus. Yeah. Great. So can I have our next question up from our moderators? So aside from the evidence, how do we include anecdotal aspects and account for practical clinical issues in the guides? I'm going to come to Sarah with this, because I know that this was something we had with the GCA and certain aspects.
It's really important with giant cell arthritis, because there are some things that you would not want to test in a clinical trial ethically. So we wouldn't want to do a clinical trial of, let's see what happens if we don't give patients any treatment. We would always want to treat someone with steroids, giant cell arthritis, because we know that early steroid treatment prevents blindness. So there are some things that we strongly believed in, to the extent that we wouldn't suggest testing them in trials, and yet we couldn't produce an evidence-based statement because there had been no clinical trial of this question. And so after much to and fro with the BSR standards and guidelines committee, we decided that this section of our guideline was going to be called general principles, and they weren't evidence-based recommendations, but they were statements which we voted on to show that we agreed, and they were perhaps the more practical clinical aspects. And so we did things in that, like, suggest a standard set of blood tests and other investigations to do at baseline giant cell arthritis. We suggested things like a steroid taper that you would do as a default and then adjust for your individual patient, but something to start from. And it's just to really give a snapshot of, this is current clinical practice. This is what most experts believe is reasonable clinical practice. It is not supported by clinical trial level evidence, but to write a helpful guideline, you have to put this as the context in which the trials are done. So we fought quite hard to keep the general principles in and to give them prominence within the guideline. And I think at the end we got the right balance.
Mm-hmm. No, and Ian, you sort of talked also in your earlier answer to one of the questions about how the challenges that you wanted to be very evidence-based, but then you wanted to produce a guideline that was useful for clinicians. So sometimes had to step outside of your comfort zone of, but we've got a strong opinion. Is that a fair way of interpreting?
Yes, exactly. So an example of that perhaps is in relation to many of the biologics, which when we were writing the BSR guideline, it was based upon evidence searches performed up to December 2013. It took a while to get the guideline to finalization and presentation at conference and publication in 2016. So that there was a reasonable amount known about TNF inhibitors, but little published on many other biologics. Because many of these drugs shared similar structures of the IgG molecule, we could perhaps, although there was little pregnancy experience to talk about certain drugs, we would draw upon experience from TNF inhibitors with the same structure to talk about when they might be transferred from mother to baby and thus potentially safe at different times of pregnancy. That was a sort of a pragmatic compromise to saying no evidence for many of these things, which would have made for a fairly short and concise guideline that was less informative, I think. And the sort of the pragmatic approach to say, okay, well, we'll try and give you a consensus-based opinion on what we think is something sensible and hopefully helpful to say about and that can be used when counselling a patient.
Yeah. And I think that approach has been really valued by clinicians. So I just noticed, just quickly, I've just been scanning the chat, that Georgina's asked about, we've talked about the role of patients and medics, but how many specialist nurses get involved in guideline development? I suppose just to get a bit of a flavour as to who else, AHP-wise and health professionals, were involved in your guideline groups. So, so Sarah, what sort of breadth of different types of clinicians?
We had a nurse on our guideline group, and she was great, and she really, in a way, she helped bridge the gap between the patient perspective and the doctor perspective, because nurses, they do offer a whole other view onto clinical conditions, and it was really useful to have her involved. I think if we were to do it again, we'd try to maybe to have more than one nurse. Again, just because I think it is quite challenging to be like the one nurse in a massive group of professors and famous clinicians. She was brilliant and she didn't have any problems. But I think if you were just getting started, you probably would want to do it with a friend rather than be the only nurse.
I suppose a bit like from the patient's perspective, it's nice to have more than one patient because it's quite, And Ian, who else did you have in your group for as far as AHP involvement? And
yes, we had clinical nurse specialists, and we had a pharmacist involved in our guideline as well. And I think I'd mentioned we had a general practitioner to represent the sort of primary care input as well. They were the sort of perhaps the most relevant stakeholders to the prescribing pregnancy guideline.
Yeah.
And I'm just thinking of other guidelines that we've got on the go at the moment, like the foot and ankle. We've got lots of AHP involvement, haven't we, in the working group for that? And I'm trying to think, Ian, you'll be sort of more up to speed with each ones, but the working groups are quite broad, aren't they, in ownership? Not just covering specialties, but covering different AHP roles. Is that fair?
Yeah, absolutely. And I think certain subjects lend themselves much better to having a broader spread of AHP representation. So as you mentioned, foot and ankle, that's a guideline that's in development, will be one that I think will have broader representation than perhaps the two main ones that Sarah and I have been today.
I'm pretty sure like our lupus, Sjögren's all had nurse specialists involved in those. So we have very much, it's not just consultants, medics involved across different specialties. So I'm going to come back to our moderators to ask for our next question now. We'll stop trying to do their job. Someone had to bring COVID into tonight. So does the process differ for the rapid COVID-19 guideline? So I think that might be one for me to answer. So, so the answer is yes, because the COVID-19 sort of guideline or guidance has had to be brought together at tremendous speed, and we have been very, I think it's fair to say, very upfront, that quite a lot of what we've had to do is a sort of, I don't like saying best guess at the moment, but it's probably about as scientific as we can be. But, some of what we've had to produce has had to be a sort of pragmatic and practical approach to the current situation where we have very, very little evidence. But what we have tried to do with some of the questions as they've formulated with time is to to update those if more information has come out to change. So, you know, a good example, for example, is the steroid guidance, which came out, which is just gone through a review process and has very much had the background rewritten and some of the doses tweaked and such. I know, Sarah, you've been privy to and cast your eyes over that and lent your expertise, just to get the context right, because I think the first iteration of that was very, you know, steroids are really scary, please don't use them, sort of thing, was the sort of message, though the guideline then said, well, use them sensibly when you need to. So it was just getting the context and the messaging right. Is that a fair comment, do you think, Sarah,
and
about that?
it's this scoping process that is really challenging at the start and is actually probably more of an iterative thing you do throughout the guideline. And it was such a rapidly changing situation that something had to be got out there, you know, early on, and then you listen to feedback, and then you just improve it iteratively. And I think for guideline development, protocols were not set up for rapidly changing situations like global pandemics. They were created for relatively stable situations where you could get everything done. The evidence wouldn't change that much between when you started the guideline and when you finished the guideline. And as we found to our cost in giant cell arthritis, if the evidence does change, then it doesn't work quite so well. So I can only imagine the difficulties that people developing the COVID-19 guidelines have had.
So, and I think the other thing to just sort of say about the BSR, that the COVID is that it has been very much more guidance rather than a guideline. It's practical advice, and then where we've very much tried to signpost members to important documents that have been produced at speed. So NICE has done a number of rapid guidance for our specialty to help guide clinicians as to how to step down services, how to start them back up again. We've had obviously the steroids we've mentioned already, and then we've had the BSR risk stratification for shielding. So I think it's fair to say we haven't been able, it's not been like the normal BSR guidelines at all. It is very much guidance and practical advice based on the best that we can do at this time, and we continue to try and keep it as up to date as we can as more information comes out. So I'm going to sort of breathe a sigh of relief, and I hope we've tackled that question well enough and ask for our next question from the moderators. So another member has asked, I'm unable to attend this evening, but I'd really like to get involved with guideline development. What do I need to do? So I might come to you, Ian, as what can people do? How can they get involved with guidelines?
Oh, no, design writes a guideline,
oh, no.
and you think there's a gap, then you could always propose one. You can find details on the BSR website of what sort of information you need to put in a proposal to send through to the Standard Audit Guideline Working Group, which is then reviewed by the whole group, which has to sort of include not just the subject area, but the background, the needs, the gaps in knowledge, and what the guideline will add in relation to other existing guidelines that might be there already. That's of course quite a daunting to be explained and carries quite a lot of large burden of work. If you want to take part in the sort of become a member of SAGWOG and then take part in the review process, it involves attending 2 meetings a year and answering a sort of regular round of emails and reading and reviewing guidelines, which can be quite an onerous task when there's lots in development. That sort of waxes and wanes, the frequency of that. Then you need to keep your eyes peeled for the BSR website for opportunities as members retire or people move on to other things. Then gaps will arise, and we will probably take the opportunity to advertise specifically for sort of gaps. There might be gaps for clinicians or gaps for allied health professionals and or clinical nurse specialists to fill. So we might sort of try and fill gaps by advertising accordingly. But those are the 2 main ways really to get involved.
And I think you've potentially got a couple of places maybe coming up on the working group, I think, if I remember rightly from your last meeting, Ian. So it was a good plug. So
we may well be advertising for professionals. We're still, so I think, assessing that thought and haven't yet moved on formulating any adverts, but they may be keep your eyes peeled in the near future.
Great stuff. Great stuff. And I'm aware our 45 minutes is fast approaching, but I think we've got maybe time for one more question from our moderators. So with so many, I don't know, there were so many people involved in writing a guideline. How can you prevent becoming disjointed so the guideline reads clearly? I think I might come to you, Sarah, here, because you had a massive group, didn't you?
47.
Challenge. Yes.
So it was a challenge. But actually, it's the sort of thing that happens quite commonly in our everyday lives. We're quite often asked to produce consensus documents within our rheumatology departments, COVID-19 being an example. And I've also been involved in sort of consensus processes like OMA Act, which also involve sort of marshalling a large number of diverse perspectives and coming up with something coherent. So it is a challenge. There are various techniques you can use for collaborative writing which help. And if you want to contact me directly, I can take you through some of the techniques and tricks that I used. And that might be a whole subject for another seminar another day.
Oh, well, brilliant. And I completely forgot to sort of highlight, because I know everyone who registered for tonight was asked to answer a couple of questions. So the first one was, have you ever used any BSR guideline? And 71% said yes. So 35 out of 49 people who registered for tonight. And are you familiar with the process by which BSR guidelines are produced? Only 16% said yes. So I'm hoping after today's or this evening's discussion, I should say, that we will get a few more yeses on that, because it's been fascinating to speak to you both, and thank you so much for talking so passionately about how you've got involved. And I have no doubt that you will have enthused some people to get involved with the process, either by proposing or getting involved with contributing to working groups, or getting involved with the committee work that sign off. We're very proud of our guidelines at the BSR, very proud to have NICE accreditation, and that in itself was a huge achievement. And I think nod to Joe Leddingham, who led that process through, who was the predecessor. So it was myself before Ian, Joe before myself as chair of that. Such a huge amount of work, but that's why we get so particular about the BSR and following the protocol and the grade processes, because we want to maintain that really important kite mark. So thank you all for tonight, and thank you so much for all the questions on the chat. And it's been a real pleasure speaking to you both, and thank you for all your personal experiences and taking us through that journey. So to just sort of wrap up, to let you know that your certificates will be emailed, and the recording of tonight's webinar will be emailed out to you when you log off or close down. There's a feedback survey. I'd be very grateful as ever if you could complete that, and take a look. We've got a number of other webinars coming up, including the one on Thursday, which is, as I said, a bit of an update because I was going back into lockdown. I'm back in the hot seat hosting, and we've got Liz Price and Karen Walker-Bone talking about shielding criteria and high-risk patients, and how we assess risk in our patients at this time. So we're back on the COVID hot seat, but we only had one COVID-related question, or maybe two, didn't we? But thank you both for your lively discussion. It's been an absolute pleasure and a privilege as ever to host this webinar. Thank you.
Thank you. Thanks, Lizzie.
Thanks, Lizzie, and thank you all for listening.